Good morning, everyone. This is a case of a 53-year-old man who presented with giddiness, left lower limb weakness, and an episode of unconsciousness 2 years ago. His MRI was done, which revealed a well-defined altered signal intensity lesion measuring 1.9 into 1.5 into 1.8 centimeters at the level of foramen of Monro, causing its obstruction and leading to upstream dilatation of the lateral ventricle. The T1 weighted images revealed iso-intense signal peripherally and hypo-intense centrally on T2 weighted images. On FLAIR sequences, the lesion showed peripheral hyperintensity and central hypointensity. The central component of the lesion showed signal drop on gradient sequence. We received multiple irregular yellowish soft tissue pieces which aggregated to 1.5 into 1.2 into 0.3 centimeters. The histopathology is very typical of a colloid cyst. This is a cyst lined by simple columnar epithelium showing cilia at places and pseudostratification. The cyst wall is fibrous and the lumen contains eosinophilic material. So a diagnosis of colloid cyst at the foramen of Monro was given. Coming to discussion, colloid cysts are benign unilocular epithelial line cyst and the lumen contains mucinous material. The histogenesis is uncertain, mostly of endodermal derivation. These are usually found in the adults in the age group of 20 to 50 years and are rarely found in children. The site, radiologic and pathologic features are very distinctive. The most common site is the anterior third ventricle near the foramen of Monro. However, they may be found at other sites such as cerebellum, frontal lobe, and pontomesencephalon. So the cysts may be of varying sizes. A cyst of usually smaller size may be asymptomatic. However, those cysts which are symptomatic, the patient commonly complains of headache, nausea, vomiting, which is secondary to the obstructive hydrocephalus. Sudden impaction causes transient lower limb paralysis and may be even fatal. Other symptoms such as diplopia, memory issues, and vertigo may be present. Sometimes the cyst may rupture and mimic an abscess. Rarely colloid cysts have been cited as a cause of sudden death. Imaging findings. On CT scan, colloid cysts appear as well-defined round to oval, slightly hyperdense compared to the brain parenchyma, but may occasionally be hypodense or isodense. The size varies from few millimeters to 3 to 4 centimeters. The contrast enhanced CT shows thin rim of enhancement and this represents the cyst capsule. MR imaging is considered superior to CT scan and usually has a variable appearance. MR imaging shows intracystic fluid levels or central and peripheral components in the lesion. Usually there are no differential diagnoses for a colloid cyst, but in atypical cases, it is worth considering other masses which arise in the region of the foramen of Monro, which includes calcified or hyperdense meningioma, intraventricular glial tumors such as pilocytic astrocytoma or ependymoma, blood in the region of the foramen of Monro, small dermoid cyst, and a craniopharyngioma. So grossly, they may vary, the size may vary from few millimeters to 3 to 4 centimeters. These are usually rounded unilocular cysts with thin glistening wall, and the cyst contains turbid or viscous material that solidifies after fixation. Now in lab, what we get is a fragmented part of the cyst and the mucus. Histopathology is very typical in a case of colloid cyst. The fibrous cyst wall is hypocellular. It is lined by simple columnar epithelium with variable cilia and or mucin, and the epithelial lining resembles bronchial epithelium. It may be flattened or even pseudostratified. Unlike Rathke's cleft or interrogenous cyst, the lining epithelium is not prone to squamous metaplasia. The gelatinous material which is present in the lumen of the cyst commonly contains mucin, old blood, or even cholesterol clefts. Fragments of normal choroid plexus are frequently found attached to the cyst, so this should not be mistaken for a choroid plexus papilloma. The cyst contained may show ghosts of desquamated lining cells, eosinophilic filamentous material resembling actinomyces. In chronic lesions, xanthogranulomatous reaction may be present. So differential diagnosis here is a ruptured epidermoid cyst, a choroid plexus papilloma, or a degenerated choroid plexus. Immunohistochemistry is not required, but the lining epithelium will be positive for cytokeratins and EMA, and the mucin may be demonstrated by fast stain. Treatment and management depends if the colloid cyst is found incidentally or is symptomatic. The current treatment options include craniotomy with excision via transcallosal or transcortical route, endoscopic removal, and stereotactic aspiration. Thank you very much. Please like and subscribe my channel. Have a nice day ahead.